right. Can everyone see my slides? Okay. Well, it is a pleasure to be here and, of course, talking to this group. And so thank you for joining. I'm going to talk a little bit about the rationale and genesis of the AIM-HI program, as well as kind of where we are with our awardees and to set up in the briefest way, kind of the subsequent symposia series, which will look at their individual projects, as well as have experts discussants from around the community who can contextualize some of the exciting projects in broadly what's happening in the field. I'll be joined, as Mark said, by Tommy, who was really foundational and instrumental to the work that this program involves. AIM-HI is the Augmented Intelligence in Medicine and Healthcare Initiative. And so I think its work is very relevant to the kind of work that's happening, the challenges that we're all facing in our local settings. So I think by now there's no doubt that AI will transform healthcare, and I'm just here highlighting some of the recent books that have been written, whether from Eric Topol or Bob Wachter, Robbie Pearl, or Peter Lee and colleagues that describe, and these are just, I think, within the past year, that describe various aspects of the revolution that's taking place with respect to Gen AI, or deep learning and its impact on medicine, or the compendium of digital tools which are coming online. If anything, when I tried to pull down various statistics related to AI, whether that's funding, papers, or the parameter sizes of Gen AI models or foundation models, everything on the internet feels too old for where we are just today. And that's because the pace of change has become so rapid that it's actually even really hard to keep up on a weekly or monthly, certainly even on a quarterly basis. So we're in the midst of this time period, and I think you probably all share this feeling that, again, that AI is poised to transform healthcare. And if anything, it's even difficult to keep up with what's coming. And yet, the evidence of how that impact will happen remains very limited, particularly with respect to whether those tools will be effective or not. So this was one example of different studies that have been done looking at an overview of RCTs of AI, and this was published in medRxiv in 2023, a group that included Eric Topol as well as his colleagues and our first author, Han. And they basically did a systematic review of papers in which AI was tested in RCTs. And nice paper, nice summary. I'll highlight some of the key points. The first is that the vast majority of studies involved medical imaging of some type, often video or static images. They were also tended to be conducted in single center settings and dominated by, studies, for example, done in the US and China that comprised about 60% of the overall. Most studies evaluated technical performance of algorithms in clinical settings rather than evaluating the impact of AI on clinical outcomes. So in essence, kind of a technical performance, maybe comparing one modality versus an unassisted approach, but really not answering the question about whether the implementation of some of these tools would actually drive meaningful patient outcomes. And then, again, the study diversity raised some questions about generalizability of findings. So our hope is that RCTs of AI in clinical practice with meaningful clinical outcomes will become far more common and will follow the exponential curve of developments we're seeing in AI or technical evaluations of performance. But as of today, we're still facing a paucity of this quality of evidence to really help us guide us about the implementation of these into clinical care. I'll harken back to some of our own internal experience with AI, and that's, I think, highlighted the challenge of implementation. And that's the part of the rationale for why the evidence base has been limited. So just probably our longest running example, we examined deterioration in the inpatient setting. We know that inpatient deterioration on the wards accounts for only 3 to 4% of hospital admissions, but accounts for as many as 25% of hospital deaths, ICU admissions, and ICU days. There's indication that these may be preventable and related to conditions present at the time of admission. And on the right here, actually, we've known about this for a long time, probably for more than 30 years. This is a publication in JAMA in 1990, which showed that patients admitted to the ICU from the wards or intermediate ICU locations were at far greater actual versus, observed versus expected death rate than those who were directly admitted from the ED. And so we have worked for a long time, and others as well, in this space on using signals from the EHR, consuming them with, various algorithms, and then using those to drive changes in the way we care for patients. And that has taught us a lot about the complexity of implementing AI associated change, which we all know involves both the technical challenges as well as the social or practice or cultural challenges. So, some of the principles for the development of our SCORE Advanced Alert Monitor were to identify the high-risk patients, but that wasn't sufficient. We had to respect patients' goals of care because many patients don't want more aggressive or invasive interventions when they are undergoing, when they're in the hospital. We know, as many as a quarter of patients come in with limitations to their goals of, to wanting invasive or life-sustaining therapies. Also wanted to give clinicians enough time for action so they weren't running, but walking to these patients. And then ultimately, and really important, to minimize false alarms for busy clinicians. That involved a huge amount of work with our colleagues, nurses, physicians, and others about what the timelines for intervention were. Again, that, some activities within an hour, others within 3 hours, others within 6 hours. This also involved social services, palliative care, to make sure there was kind of a holistic approach. And again, a walk, don't run type approach to these patients. There's a lot of work that went into the pre-go live as well as the post-go live that had to do with aligning stakeholder engagement, kicking off meetings, assessing hospital readiness, education training, practice runs, simulation, hospital communication, all of that stuff. And then after go live, the huddles and performance improvement. I think many of you are quite experienced with this, whether it involves AI or not, but change management when it involves implementing new technology. Ultimately, we had to change or think about the way we communicate to patients. Instead of this score is, shows that you have an 18.4% risk of X, Y, or Z, to couch it in kind of an additional tool that we use in addition to all the other mechanisms we have, including rapid response teams and others, where we are monitoring patients, doing our best to capture risk profiles that arise from routine labs, routine vitals, eyeball tests, other clinical care patterns, all of that, which is working together to best manage a patient's care. We were delighted to find in this study, I think it was published in 2021, that the use of this system decreased death within 30 days after the alert in patients who were flagged as high risk in hospitals that had gone live with the alert versus when they hadn't. And also to address the concern that an early warning system would push more patients into the ICU, we actually also saw a decrease in the amount of ICU admission. So, hopefully that patients were being cared for earlier in the process, and thus mitigating the downward trajectory towards ICU. What this doesn't reflect is also that, these are clinical decisions made by teams that are communicating more about patients. And There's also increases in the use of goals of care documentation and other services to support, again, patients who ultimately don't want more aggressive or invasive care. When we've taken a lot of those learnings about this kind of traditional AI or AI assisted care and evaluated their clinical outcomes in other domains, this paper was a look at an algorithm which we implemented along with a care team called the Transitions Program to reduce readmissions among medium and high risk patients. And here you can see those are outlined in the blue, in the red, after looking back over essentially a 10-year period of observed versus expected 30-day mortality or readmission, and a decrease in readmissions, and not among those patients who are not targeted. That's the low risk patients. We've subsequently evaluated a risk score in those patients in order to align them with the Transitions program as well. And hopefully we'll be able to report on that shortly. This is work done by Mike Kuznowitz here, as well as others, my former mentor, Gabriel Escobar, looking at a neonatal sepsis calculator. And the use of this score led to a reduction of 50% or so in the use of blood cultures and antibiotics in a baby's first days of life, with no associated increase in adverse outcomes. So, good experience with traditional risk calculators when they become embedded into our social technical fabric for care. Jonathan Volk, Mike Silverberg, as well as others, their colleagues in Boston, did a randomized trial of alert to inform HIV pre-exposure prophylaxis care. This was just recently published, and what it showed was that among providers who received this alert, who had a panel with HIV patients or were familiar with kind of HIV care, the alert drove a large increase in the linkage of those patients with PrEP services, but actually it didn't have an effect among patients, among provider groups who did not have a large degree of familiarity or panel that was with HIV patients. So, a tempered effect, but one which helps us learn, how to deploy these types of interventions more effectively. And then in the more Gen AI space, we recently looked at the deployment of ambient AI scribes in order to alleviate the burden of clinical documentation. And this is a pretty exploratory study because it was early on in our learnings about using these tools, but this is based on 3,000 to 4,000 providers who have used the tools in some of their interactions with patients in order to listen to the conversation, transcribe elements, and then provide a summarization to reduce that burden of clinical documentation, and also to improve the communication between patients and providers, so they're not spending all their time, keying in on the keyboard or a computer screen. And in our preliminary analysis, we found that those who were users of this tool had larger decreases in the time they spent in notes per appointment compared with groups who were offered the tool but hadn't yet used it. And so, again, learning a little bit of how we evaluate meaningful clinician or patient outcomes with respect to some of these emerging tools. And the final example I'll give is this study where we looked at over 5 million messages initiated by patients to their providers, and a large language model or a way to flag messages for specific content. And you can see these are some of the areas that this pipeline flags patients' messages. And then the use of a regional service with medical assistants, pharmacists, physicians, and other teleservice representatives to try to address those issues in a focused way to prevent those messages from having to go on and overwhelm an individual physician's inbox. A couple of things we've learned from this process is, first, that the content of messages is remarkably well preserved over time, meaning that systematic and regional strategies like this could be part of a system designed to effectively alleviate the burden of inbox overload. The second was that a labeling system. It wasn't a labeling system that just labeled everything. Each of these was tied to a very specific and characterized workflow, so that this is not just AI running loose through messages. Instead, it's clinically oriented pathways that we're using AI to try to accelerate the time to identification of the messages so we can resolve them faster. And this system reduced inbox messages ending up in individual physician inboxes by roughly 30%. So a reduction of as many as 1.5 million messages over about a 6-month period. So, we've had a lot of, obviously, excitement, experience about some of these challenges. Part of that has led us to frame that, AI was effective when integrated into clinical care as augmented rather than artificial intelligence. And that's because we think of AI augmented intelligence, placing people, patients, clinicians, and communities rather than algorithms at its center. And not to get too scientific about it, but this involves this really careful collaboration of not only the data science expertise, those are the AI ML prediction researchers, IT platform teams, etc., but really with our people, our operational leaders, our clinicians, ultimately patients. And where we can succeed in kind of bringing those together, the kind of social, technical aspects of this type of AI-enabled care, I think we have pretty tremendous opportunities to see effects that are positive for our patients and our clinicians. But without that effective handshake or handoff, I think everybody's experienced that there are tremendous struggles and challenges. And yet, with that experience and the experience that you have in your different institutions, cresting that AI vista showed us there's still a large frontier and gap that we need to get to. And in fact, again, just keying back in on the kind of challenges of the rapid pace of change with respect to Gen AI, has only made this the need for high quality and rigorous evidence, methods, and approaches that we can effectively use to meaningfully deploy these tools. It's only made that gap more stark. And that was a lot of the genesis of kind of the conversations that we had early on with Tommy, as well as the Moore Foundation. So with that, I'm going to stop sharing for a second and give Tommy a chance to give us some of his thoughts.
Thanks, Vinny. And I'm going to keep my remarks pretty brief, as seeing that most of the folks on the line are from health systems. I don't want to speak to the choir of things that all of you are actually experiencing. So for 3 years, I led the technology strategy of the Diagnostic Excellence Initiative at the Moore Foundation. And what this translates into is primarily identifying and executing on grant-making opportunities at the intersection of health and AI. In particular, here we're talking about evidence generation and the implementation evidence gap. And I'll just provide a little bit of the motivation. Just to paraphrase the line from the Rime of the Ancient Mariner, there was a sense of models everywhere, and not a one with evidence of impact. And that's not the same today. It was more the case 3-4 years ago. But there was a sense of frustration of, wow, look at all these amazing papers of what could be done with AI. Look at how we've estimated this impact and hypothesized, but nobody was actually doing that hard work of implementing and translating that, and all the challenges of embedding a AI solution into a complex healthcare delivery environment. And early on, we actually were fortunate enough to fund a RCT that relates to identifying acute coronary syndrome in the ED setting. And through this work, it was that trial is actually ongoing. But our team thought more about how is the best way to impact this? Are we going to set about funding every RCT or every prospective evaluation in the space? Probably not. That needs to be a community that emerges and other funding sources as well. And so in our conversations with Vinny, that's exactly what we set out to do, to think about how do we launch multiple evaluations at the same time so that we can build out the community that will think about what are the research methods that work in this field. Is it all RCTs? How do we think about the practical evaluations of running these within active health systems? What will be and what is the role of real world evidence generation, especially when you think about the ongoing monitoring needs of a lot of these technologies. It's not a one and done type of situation. And there really is the strong need to identify the best practices and thinking about once you do have this shiny new object over here, the algorithm, then what does it mean to work in the healthcare setting? And it's all the things that Vinny has mentioned, the technical factors of making it integrate into your IT system, that you can actually get the data out that you need, and it's not sitting in this research repository, and that you're going to be able to do this as if it needs to be run on a daily, hourly, or minute by minute basis. Thinking about the operational challenges, especially around clinical integration and how it interfaces with the human workforce within the health system. And so these conversations led us to think about, well, how do we, instead of funding a particular RCT, select a set of RCTs or select a set of health systems that are engaged in this type of evaluatory work, which aren't necessarily going to be RCTs, I should say. And so we were thrilled to work with Vinny and his team and to fund them as a coordinating center, which turned into the AIM-HI effort. And to think about how do we identify and select health systems across different use cases, across different sites of states, and different resource levels of health systems as well. So I think Vinny now will take you through the process we use to select and then identify the 5 health systems that are part of the AIM-HI initiative.
Great, thanks, Tommy. So that's great framing, and we had a lot of conversations with core team at the Gordon and Betty Moore Foundation, as well as informed by other expert conversations with those who have been thinking in this area. And what I can share is some of the thoughts and some of what we saw behind the scenes, but this process is ongoing and accelerating. So the objective of the AIM-HI program was to advance research methods, identify best practices for scalability, and build capacity for effectively implementing and rigorously evaluating the use of AI and ML algorithms for diagnostic decision-making in real-world settings. So that's actually a lot to put in one place, but essentially, how do we get to the rigorous evidence we need of AI and ML algorithmic use in actual clinical settings for diagnostic decision making? So we started with a request for proposals in 2023 to support this kind of research that evaluates real world implementation. Our goal was to provide 2 to 3 years of funding for 3 to 5 proposals of this prospective work in US health systems, where we would be acting as the coordinating center overseeing the work and advised by a national advisory committee. I will say we were fortunate to eventually get funding for 5 proposals instead of 3, because choosing just 3 would have been quite difficult, and we were able to secure funding for each of the systems to get $750,000. So a substantial amount of funding, but not on the scale of traditional trial, let's say, run out of the NIH, and less than some of the R01 level funding, for example, from the NIH, but enough to really, I think, accelerate these evaluations in cases where things were really shovel ready to be deployed. In terms of our areas of focus, aligned with other priorities within the Moore Foundation, it really focused on diagnostic decision making. And I think we all know the rationale for that. Millions of Americans are subjected to medical errors each year, of which diagnostic error is identified as one of the major contributors. We believe that these algorithms offer uniquely powerful capability to enhance diagnostic excellence, and that could be through a variety of different mediators. It could improve risk stratification, decision making, diagnostic testing approaches, and interventions. And I think, again, propelled by what we've seen out of Gen AI over this past year, I think there's, again, a lot of excitement that even those new and emerging tools could further help in this process and streamline a lot of that work. Because there were priority areas for the patient care program within the Moore Foundation, we were interested in priority areas, those being cancer, acute vascular events, and acute infection. But we welcomed applications from any medical or healthcare domain, mostly because we wanted to make sure that we got the breadth of what folks felt, and this is in early 2023, were really kind of prime time or ready to be evaluated. There were a number of decisions that we knew we might have to face, and we kind of went back and forth in our discussions about how to set up this request for proposals. And really prioritizing a balance between health system settings. So, being able to speak to how AI and ML would be rolled out in more resource limited settings beyond large health systems and academic medical centers. So, if we focused on shovel ready projects or projects in which the impact was, all of the resources were in place and the sample size was very large and adequate, there would be the concern that safety net type settings or more community settings would be excluded from these evaluations. So that was something we kept in mind, because obviously how AI ML gets deployed in healthcare more broadly, not only in the US but across the world, is of primary concern to our society as a whole. The second question was, what would be the breadth of the clinical domains? And we didn't know going into this process, would we more focus on going deep within a specific area, like imaging, like cancer, or a modality like Gen AI or, deep learning, for example. And the, byproduct of that would be that we would improve collaborative learning, scalability of best practices across the site, or focus more on going broad and with the goal to identify kind of best in class projects across domains. And what we settled on was, let's see what the applications are. Let's let the best rise to the top and make a decision at that point. There was also a question about traditional versus kind of emerging AI in light of what had just been, probably a handful of months since ChatGPT was released to the world. The question was, would we identify shovel-ready projects? In general, shovel-ready projects have been already being worked on for months to years, or focus on applications within this emerging Gen AI domain. And again, we deferred this decision to see what the applications were like, and then ultimately the evaluation modality. Given the paucity of RCTs in clinical AI, what emphasis should we place on favoring RCTs versus other study designs? So we really emphasize that we would be most intrigued or interested in funding trials of some type. We recognize that in some cases, this can't be a patient-level randomization, that there were other aspects of randomization, but we made that a really high priority to try to emphasize the quality of the study design so that the results would be as rigorous as possible. We were joined by a number of folks on our National Advisory Committee, and I'll just highlight their pictures and their positions here. Dr. Derek Angus from UPMC, Dr. Alistair Denniston from the UK, who's leading a lot of AI evaluation and imaging AI and ophthalmology work for the UK and NHS. Dr. David Bates from Brigham and Women's Hospital, Mass General Brigham, expert in informatics and clinical workflow. Dr. Marzieh Gassemi from MIT, who is very interested in AI in clinical applications and bias. Maya Hightower, who is the CEO and co-founder of Equality AI, has formerly held many leadership roles in digital technology and information technology for large health systems. Brendan O'Leary was our independent consultant who was formerly working at the FDA. Dr. Beth McGlynn, who is our senior vice president at KP for research and quality measurement, as well as the executive director of the KP Caesar Center, and then Tommy, who as you heard, was a program officer at the time, but is a healthcare and organizational economist. And we used their feedback to really help us understand kind of how we should prioritize applications and make sure that we were moving ahead in an effective way. So this is just a brief timeline. We went live in May. We closed out our LOI stage in June. We then spent July going through 125 letters of intent, coning those down to 60, of which we ultimately chose 12 to submit full applications. We gave them the summer to work on those applications, ultimately coming down to 10, 7, and then ultimately selecting 5 for funding. And they were notified just 4 months ago now that they had been awarded, and they've been hard at work in terms of getting their IRBs approved, getting their study protocols written up, getting technical integration and social integration underway. So among just a little bit of insider's view on the 125 letters of intent, we did have a small team of researchers review the letters of intent to assess them for overall responsiveness to the RFP. And we determined that, about half of them didn't require further review by scientific staff. And here are some of the reasons why they were removed. They focused entirely on algorithmic development rather than on real world implementation. They did not provide an evaluation plan. They didn't, specify how the work was going to be executed. They were not focused on diagnosis or otherwise not responsive to the RFP. There was no intervention. It was only validation of a model. The research was focused out of the US, or it was kind of boilerplate marketing material. There was no actual rigorous evaluation that was being proposed. Tommy and others have done a little bit more of a deep dive, and we're hoping to publish kind of some learnings from what we received, because I thought this would be highly informational in terms of kind of what people around the country were thinking was shovel ready. So of the 125 submissions, we actually got the majority of states represented overall. And again, there were some international applicants. 4 states, those being Georgia, New York, Massachusetts, and California, made up about 41% of those submissions. And I think, we've seen something similar from other reports in the past that states like New York, California, Massachusetts, and some others tend to dominate a lot of the literature as well when it comes to AI algorithmic development. There was a proportion, although small, that had a specific focus on the pediatric population, 10%. About 40% involved some collaboration with a vendor or a startup entity, so a commercial partner in this process. And then, a modest number that proposed study involving a large language model or NLP as the core of their evaluation. In terms of how they were aligned with priority areas, 19, 17, and 8% respectively related to cancer, acute vascular disease, and infections. Beyond those, the next most common were maternal health, mental behavioral health, and surgery, with each of those close to 8%. So I think that shows you a little bit of, again, for this shovel-ready diagnostic decision support implementation and rigorous evaluation, kind of where people are thinking that the potential use cases are most promising. There was a quarter of the LOIs that represented collaborations across multi-health systems and or states instead of just single sites or single health systems. And the LOIs were dominated by academic medical center, followed by technology companies, universities alone, healthcare systems alone, or public health systems. So it gives you a sense of kind of where people are focused. For the sake of preserving confidentiality, I'm not going to go into all the specifics of what different studies were or the titles, but again, we'll be publishing a report that describes some of what we saw as kind of a snapshot, a cross-section of what folks in 2023 felt was most promising for this type of rigorous evaluation. We had 23 DOR scientists, Division of Research Scientists at KP, review these in an NIH style, 3 reviewers each across these 5 domains. We had additional assessments from our AIM-HI leadership team, and then ultimately our NAC reviewed all 20 of the top scoring applications and helped us to refine down to the 12 that were invited to submit applications. This is a replicate slide. So I'm going to quickly just highlight the awardees and let you know that we will have subsequent symposia in this series in which our awardees will present the rationale for their study, what their algorithm is, what their study design is, and give an update on where they are in the process. We are having our first quarterly check-ins with them, and I'm glad to report that everyone has had their IRBs approved because, as you all know, that's an area where we're sometimes facing challenges internally with respect to kind of the changing regulatory landscape. In the symposia series, we'll also have an external expert discussant who, as I said before, will contextualize some of the work against what's otherwise happening in those fields. But we were really excited to go broad, which meant that we chose a diversity of health system settings, a diversity of AI ML modalities, a diversity of clinical domains and populations. And I think we were really excited to support each of these. Each study is doing an RCT, and so we congratulate and applaud all of our awardees for really amping up the rigor of the study, even with this kind of limited amount of time and funding, really to execute on these evaluations. So Siva Bhavani is at Emory University, and he's joined by many investigators at Emory. And this trial is called the PRECISE trial. And I'll just read off this summary. It's a pragmatic, single-blinded, patient-level randomized controlled trial that will be conducted across Emory, including their tertiary center, hybrid centers, and community hospitals. And what they're doing is using a machine learning algorithm that was validated to identify a subset of patients and randomize them to usual care or intervention using an EHR alert that nudges clinicians to use balanced crystalloids instead of normal saline to evaluate reduction in 30-day mortality. So they're underway with an EHR embedded algorithm that nudges clinicians to make a specific choice about fluid balance in a subset of patients that have been shown to likely have a benefit from that fluid choice. Peter Emby, who's at Vanderbilt, is joined again with a large team from his institution. and they're going to be looking at novel approaches and best practices for effective randomized trials, algorithmovigilance, and proactive risk assessment in venous thromboembolism. So again, I'll read this off. The proposal plans to evaluate HAVTE specific AI-driven clinical support systems across rural and urban sites and among adult and pediatric patients. They will also be refining and building approaches for real-world algorithmovigilance, going beyond just the trial to focus on real-time and sustained monitoring of AI tools. So extremely ambitious study looking at two different algorithms, adult and pediatric patients in academic and community settings, as well as the ongoing monitoring and maintenance of those algorithms. So we're excited to participate in all or support all parts of this extensive application. This is Dr. Fatima Munoz, who's from the San Isidro Health System, joined by some colleagues from that site as well as UCSD. And so they are an FQHC that will be examining the use of imaging AI technology for diabetic retinopathy screening. So they will integrate this imaging AI technology into the EHRs to increase access to retinopathy screening within primary care. So the goal is to make this as seamless as possible, move patients through to get the right care when diabetic retinopathy is at risk. And they'll be partnering with a company called INOC, who developed the technology deployed within specialized cameras in order to do that. Dr. David Oyang from Cedars-Sinai and joined by colleagues from Palo Alto VA, Northwestern, and Providence. And they will be also using imaging AI to look at screening algorithm to identify underdiagnosed cardiac amyloidosis in echocardiogram. So this is using a already validated algorithm to identify risk for amyloidosis and then randomizing patients to a screening strategy or a diagnostic workup strategy to see whether earlier identification for cardiac amyloid can improve their patients' outcomes, as well as whether it's feasible to use such a system really to effectively and efficiently identify these patients. And then finally, Dr. Cesar Timulo from Parkland Health, joined by folks from two FQHCs as part of their network at Foremost Family Health, as well as Los Barrios Unidos Community Clinic. And they will be taking an already developed risk prediction model for using EHR data to identify pediatric patients at high risk for asthma, acute asthma utilization in the emergency room, deploying it in two new EHR systems, including a text messaging app that they've used in the past to reach out to these patients, also to alert clinicians about how to optimize care for these patients to reduce emergent ED utilization. So we are extremely excited to see the breadth and range of these different projects, and they're all kicking off in various aspects of their trials or in their validation and technical integration aspects. We've talked a little bit about the Symposia series, which is forthcoming in the subsequent months. What about next steps for us? We're continuing to work on knowledge sharing discussions, disseminations, various milestones, and I'll kind of leave it at there. And I'll just end because we're close to the hour with thanks, not only for the AIM-HI team at KP, Heather Clancy, Caitlin Leiden have done extremely great work to make this a reality. Matt Solomon and Honor Shin are my physician colleagues who've helped lead this program, and Danny Shard is our research assistant. Tommy, Daniel, Caroline, all formerly of the Gordon Betty Moore Foundation who supported this, our National Advisory Board members, and then here I've listed out all of the DOR scientific reviewers who helped in this process. I will stop there and again turn it over to Tommy for some final closing thoughts.
Yeah, it's really rewarding to see the whole process laid out and then the final five awardees here. I think, the AIM-HI team and our team at Gordon and Betty Moore Foundation, we were joking around at the beginning. We had no clear sense of how many letters of intent there would be or of the quality of the letters of intent and how we would end up, you know, what would be the opportunity to select for diversity of the awardees. And so when we look at that final list, I'll just double click on Vinny's comments that it's great to see that we have use cases from the acute care setting, but also those in the ambulatory and those involving screening processes. Definitely non-urban settings. We have non-academic medical centers, and it's really great to see that two of the projects involve FQHCs. As much geographic diversity as we were able to generate, pediatric use cases, and I think it's also really important that all of the awardees are having multi-site experimental designs, if not multi-institutional, because it's not enough to show that it works in one particular clinic or one particular hospital. We've repeatedly talked about the complexity of healthcare delivered in healthcare systems. So really excited for this work to launch. We'll also add in that through the course of both seeing the applications in other meetings, there's obviously a lot of work going on both within the United States as well as internationally. So it will be also a goal of the AIM-HI Coordinating Center to try to make the linkages not just with these five funded studies, but also think about how do we make sure we're staying connected to the rapidly moving ecosystem around us and all the implementations and studies that are going to be launched and released in the next couple of years while these are going on. So it'll be really exciting to see that process of the community forming, and hopefully that initial slide that Vinny showed around the statistics on RCTs happening in this space. Hopefully we'll have a very different map in 2 years, 3 years from now.
Great. Thank you, Tommy.
So we have 7 minutes for questions. I'd like to take the privilege of a moderator and start with a few. So, Vinny, I do want to ask, and this is actually for both of you, Vinny and Tommy. Tommy, thank you for the mug. I just noticed that when you drank. When it comes to evidence generation, and when we kind of imagine the future where these projects have conducted their studies, we can imagine that some of these products, clinical care models, may be effective. And when we think about how to scale the evidence into practice, I struggle with, do you need to run this type of study again? When the next site, the next 10 sites, 100 sites want to adopt this. And something I want to kind of put in the question is also, over the years, my thinking about AI has changed, where it's hard to think just about the product versus combined products and services. And whether or not some of these studies will lead to packaged products and services that get adopted versus scaling just the AI. So broadly, just when these studies are done, let's say some of them are effective, how do you imagine that driving diffusion of implementation of these effective models more broadly?
Yeah, I mean, it's such a good question, Mark, and I think that one that's pretty unresolved in the field. What is the contribution from the AI technology itself versus all of the human integration and systems work that's built around it? And in which use case and with which AI what is the proportion? I don't think we know today. I would say, I guess my take on that is with traditional AI, like some of the examples I gave, a lot of that is a lot of the algorithm itself using traditional AI is it's okay, it's pretty good. but there's a lot of that as a smarter starter gun, kicking off a process that's much more well characterized, standardized, that's really driving a lot of the outcomes benefits. So it's kind of augmenting kind of the clinical intelligence we have rather than its dominant effect just based on the algorithm alone. Meaning, if we plopped it into a workflow, would it work just as effectively with no changes in education, no socialization, none of all of that we built around it? And I would say probably not, because that's been the story of the technology we hate. It just gets dropped in and gets discarded because nobody wants to use it. But I think that the frontier, and we are undergoing a sea change in, the type of technology, more literate, more seamless, the way we interact with it different, and its capability to identify and kind of have this almost human-like quality has changed. So I think it's an unresolved question today. And I think what these studies will contribute is, I think it's a great point that we probably need to do some additional work with our study teams to unpack that proportion, and really kind of think deeply about kind of how we quantify that and what its relevance is to future products.
Yeah, I'll just add, I see it almost as a succession of gatekeeping, where in the same way that if you don't have strong, probably third-party evidence that a model's analytic performance is up to par and across different groups, you wouldn't even want to begin to think about testing it and deploying it and implementing it. And then so the generation of a RCT in a specific healthcare delivery context gives you even greater confidence that maybe your own health system should be thinking about this. And I'll just point out that I want to point out or emphasize the question on ongoing monitoring here. And actually Peter's work with the algorithmic vigilance, that's going to be really important, because what works today at a health system may not work so well going forward. So I think you could take that same analogy, that it gives you enough confidence that, yes, this is something we should strongly consider, but every health system, every healthcare delivery setting is going to need to come up with both the technical, but then also the operational and human context infrastructure to be able to evaluate whether different solutions are right for them at that time, and when to reevaluate and when to take them off. Does that mean that they're going to have to do a full-fledged RCT? Probably not, but it does mean that they're going to have to come up with mechanisms to monitor the performance of these systems as they're performing in their health systems.
I would love to continue asking questions. We are essentially at the top of the hour. So I know, Vinny, you're going to be leading this work for multiple years. So I'm sure everyone here will have opportunity to continue to engage you and the team. I put in the chat that the next session for the first symposia is actually going to be May 9th. So it's just a few weeks from now. And then one last thing that I'll grab the link for. We would love just to get feedback from folks about these sessions. So I'll put the link here for everybody. I want to thank folks for taking an hour of your day to come hear from Tommy and Vinny. And we're thrilled to have these studies that we get to watch from the outside and learn hopefully from them and see how to most optimally put these tools into practice. So appreciate your time.
Thanks, everyone.
Thanks, everyone.